Hello, everyone, and welcome to another episode of AI in Healthcare series. I'm your host, Dr. Harshita, and it's truly a pleasure to have you all with us today. I'm thrilled to introduce our esteemed panel of experts who will enlighten us with their insights and expertise on AI in cardiology. Before we immerse ourselves in today's discussion, I want to extend my gratitude to two distinguished guests who have played a vital role in the success of this series. For returning audience, these names need no introduction, but for those joining us for the first time, allow me to introduce two brilliant minds in healthcare who are joining me once again, Dr. Dipu Patel and Dr. Amit Kumar. Dr. Amit, a renowned physician and diabetologist, Dr. Amit not only excels in his medical practice, but also shines as an AI entrepreneur, spearheading innovations that bridge the gap between technology and healthcare. Welcome, Dr. Amit. And now we have Dr. Dipu Patel joining us today. She's a digital health consultant. She seamlessly blends her clinical acumen with a deep understanding of technology, advocating for patient-centered care in the digital age. Welcome, Dr. Dipu.
Thank you, Harshita. Thank you, everyone. Welcome to our audience across all our time zones. Good morning, good afternoon, good evening. We are so honored to have our current guest today, Dr. Zaidon Al-Falahi, who is a attending cardiologist in Southwest Sydney local health district, where he founded the Medical Intelligence and Data Science Hub. He is a founding member of the Medical Intelligence Society and a convener of MIS 2022 and 2023. He is currently pursuing his PhD at the University of Sydney on smart wearables and using advanced analysis of smartwatch-generated ECGs for the pre-symptomatic detection of cardiovascular disease. We are honored to have you. Thank you, Dr. Al-Falahi, for joining us.
Thank you. The honor is all mine to be here, and thanks you for having me.
So hi and good afternoon from India. Good morning from USA. Good evening from Australia. I mean, it's a global connect we have these days, but a warm welcome to all our regular viewers and our new viewers of the podcast. This is the 13th episode, and I'm so happy that Zaidon could join us today from Australia. And it's so much happening in the world of artificial intelligence across the globe that it's really difficult for most of us to keep at pace with all the developments that's happening. And we're excited to hear from Zaidon today with all the developments that is happening in his specialty and domain of cardiology. So a warm welcome to you, Zaidon, for joining us today.
Thank you again, Amit. We meet again. So thank you. It's a pleasure to be here and talking to all the people.
It's a pleasure to have you. So let's start with understanding about how artificial intelligence can impact the domain of cardiology. So give us an overview to start with, Zaidon, about how the AI tools are being used and what are the immediate prospects of using artificial intelligence in the domain of cardiology.
Thank you, Amit. I think if I want to categorize this can be categorized in so many ways. The reason being, AI holds the promise of really transforming every single aspect of cardiology, from the general transformation of the way we perceive evidence, the way we collect evidence and practice medicine, but also in the way we apply specific cardiac diagnostics as well as intervention. But I think just to summarize into a few categories, it really changes. Some of the main applications we have at the moment that are embedded in the workflow are those that help, they're almost like autopilot features in our current machines, the echocardiograms, angiograms. It's like autopilot. It makes the procedures a little bit more comfortable to perform or a little bit easier without any fundamental changes. But in the research realm and in the possibility realm, it absolutely and fundamentally changes how we look at disease, how we are able to diagnose things we never expected the ability to be able to diagnose from a simple investigation like an ECG, which is, very accessible and relatively low cost, to extracting similar insights, or the potential for extracting similar insights from ECG, from wearables and from some smartwatches, which is the field of my study, as well as being able to predict even future events, again, not just from an ECG, but from an echocardiogram, from CT scans, from imaging. It essentially it's like finding at the microscope. It's a new lens through which we can look at data in ways we were never able to look at before. So that is on one side. On the other side, there is the usual ability to automate, to educate, to summarize, to do, especially now with the accessibility of large language models. So it touches pretty much every aspect of cardiology, and some of them in absolutely transformative ways.
I
don't
think
know.
those are. Go ahead. No, go ahead. Finish
Yeah.
your thought.
No, I think it's better if we speak about those, in more detail down the track, but it essentially changes everything. But at the moment, established workflows do include a little bit of autopilot methods, and the ability to extract more information from basic tests like CT scans or echocardiograms or ECGs.
Yeah. So speaking of ECGs and echoes, I think one of the things that you're alluding to is how it's going to change the accuracy and efficiency of diagnosing heart-related conditions. So are there examples that you can point to on how AI technology is improving or has improved the accuracy and efficiency of diagnosing heart-related conditions? Imaging certainly is a large part of a cardiology, whether it be in the screening phase or in the interventional phase. There's a lot of radiological AIs and algorithms that are out there. And I use the term AI loosely just to allude to everything, as we all know that AI is not a thing in and of itself. It is made up of a lot of other aspects of it.
So I think some of the most famous examples that has essentially, in a way, rocked the scientific community, I would say, and generated a lot of interest, is all the research that came from the Mayo Clinic about what they could do with their ECGs. And before I go into the almost, again, if something is technologically advanced enough, you would think it's magic. And that's one of the things that we initially thought, when we saw the research coming out of the Mayo Clinic. But if you have an institution like the Mayo Clinic, who have over the decades digitized 7 million ECGs or more, which is what the repertoire contains, very carefully annotated, you can do so many cool things with AI. So what they showed, for example, and that I will explain, some of the algorithms before I go back into some of the basic science behind it and why, the field is very exciting. They, for example, were able to show that an algorithm can tell who is likely to have underlying atrial fibrillation, which is a major cause of stroke in people, from an ECG when they are in a normal rhythm. So if the abnormal rhythm is not present, you have an ECG of the normal rhythm. They're able to predict the possibility that the abnormal rhythm exists in this person. In this current day and age, most of the time, the only way we can capture it is by, putting long-term monitors on people to try to capture this rhythm if we suspect it enough, and that comes at a huge cost. Apple Watches and Samsung watches and smartwatches in general have developed their own algorithms to try to capture that. But again, you need to wear the device. It's transformative if you're able to detect it from a single ECG. And the same thing goes for left ventricular systolic dysfunction, which is essentially heart failure or a weak heart, weak pump. So you're able to tell if somebody has a weak pump just from an ECG. And these things, from a simple ECG. And that really can changes how you can early on diagnose and treat these people. And also what's powerful with these algorithms is that in the right setting, they can be deployed anywhere. They can be deployed remotely. They can be deployed in remote areas. So that dependence on, on an expert reading the ECG. There's no way otherwise with us looking at the ECG to detect this information. So this information is hidden in the ECG. And we knew for a very long time that the electrocardiogram is considered a complex data set, which means that it has a lot of information that is encoded that's not immediately visible to the human eye. We just need to find a way of how to extract it. And AI is one method. There are other methods which I can, talk about later, but this is one way to have the lens to extract it. ECGs have information about your age, and if your age is higher, if your ECG predicted age is higher than your actual age, then this is a sign something is wrong. And this raises a new concept of accelerated aging and heart age, and there's a lot of research on that. The ECG can even tell your levels of certain, if you're hyperglycemic, if you're diabetic, if your sugar levels are high, if some of the solutes, like potassium in your blood is very high. There's actually a patented way of, it's like an FDA approved way of measuring your potassium just from an ECG. This can be life-saving in people on dialysis. And finally, ECGs are actually unique to you, so they can be used as a biometric to you. So it just tells you, this even takes us into a new era of you can be recognized by your ECG. These are things, and your fingerprint, and these are not things we managed to know before. You certainly can't tell this from a squiggles. And in cardiology lingo, cardiology, we just, ECGs, we used to call them just squiggles or squiggly lines. They're much more than that.
So for most of our audience out there, if you're wondering, how the ECG actually can pick up all these nuances using artificial intelligence, you're looking at using something called machine learning. And in cases of ECG, you're actually using a time series data. So something like a recurrent neural network is used in this case, which kind of picks up a pattern and then it gives the predictive analytics. These are the examples just that Zaidon was just citing to us and the fantastic use case of ECG. So one is, of course, in the ECG, Zaidon. And if you look at the other spectrum, it's the echocardiogram, where you again look at a larger set of images run through multiple iterations of convolutional neural network, the same principles which are used in radiology, and it's very well successful there. Give us your insights about how, the whole dimensions of doing an echocardiography will change with this autopilot and pattern recognitions and predictions coming. And also give us your overview, how you think it's going to impact the health inequality. Because that is also a challenge. You don't have an echocardiographer in every nooks and corner of every country. And many undiagnosed heart failure with a preserved ejection fraction or with a reduced ejection fraction gets missed, just because of the lack of an echocardiography setting. So give us your view on both these things, in the next comment.
Thank you. So I think I will break the comment into two sections. One where I talk about how you can substitute the information you get from an echocardiogram with other modalities like an ECG or like a smart enabled stethoscope. So you can detect some potentially life-threatening problems like, mitral stenosis or rheumatic heart disease with AI enabled stethoscopes. I mean, you don't really have to rely on the most experienced clinician to have heard a lot of mitral stenosis, which is sometimes hard to hear, etc. But with properly trained algorithms, and there are a few available, you can actually diagnose these conditions in remote areas with ECGs and with stethoscopes. So in that case, it actually picks up the cases and allows, at the very least, to screen the population and to enable wider access to something that otherwise would have required you to be in a center of excellence to do an echocardiogram, which is a highly specialized procedure. It takes a long time. And, even here in Australia, it's like access to it requires a general practitioner to refer you to a cardiologist, and a cardiologist will perform it. So, access to echoes is always an issue. The second part is where, so AI enables the use of other ancillary simple testing to actually pick up cases that otherwise would have only been picked up by an echocardiogram. Like valvular heart disease, rheumatic heart disease, and other conditions like pulmonary hypertension, which, can benefit from early intervention and treatment. The second aspect of echocardiogram is to make it more, to first elevate it so we can get far more accurate data, but also more insights into the echocardiograms. And second, to make it more efficient and simplified. So, more echocardiograms can be done in a shorter span of time with greater accuracy. There's been a lot of work done on echocardiograms, and for example, by using, and this is an example, by using some clustering techniques, we found that people previously who were diagnosed, and I don't want to get too technical here, but people who are diagnosed with what's considered heart failure with a normal ejection fraction or with a preserved ejection fraction, in which the heart is, the heart is failing because it's under too much pressure, but it seems to be contracting normally. We used to say that 50% of all cases of heart failure are heart failure with preserved ejection fraction. And we said there were no treatment, and we thought they were all the same, the same disease. But using clustering analysis, we found that there are so many subtypes, and we're actually going almost reverse engineering, trying to figure out what are these subtypes. Like the machine seems to think the way the muscle is being activated, the way the fibers are moving, if so to speak, on an echo are different from one pathology to another. So it actually allows us to do, probably even look further into the very pathology of these conditions. There are even some older algorithms. There's an algorithm published by the researchers back in 2018 at Harvard, shows that people who had who were being treated with chemotherapy, AI-enabled echocardiogram can detect very early signs of people who will develop adverse reactions to chemotherapy and heart failure. Of course, whether this translates to improved outcomes and changing treatment, that requires separate studies, but the data is there in case that it shows that you can pick up these earlies before our eyes are able to pick it up. And these are some of the very simple ways. There was a study presented at ESC a year ago or a couple of years ago that shows, AI-enabled estimation of ejection fraction is as good or probably sometimes even better than those by sonographers. Now, again, there are caveats there, but the fact that a simple snapshot of a video algorithm able to do such a task has a huge potential for democratizing access to these technologies. And finally, if you want to add another layer of innovation with all these ultrasonic transducers that you can stick on your skin to have real-time analysis, it just completely changes what we can do in terms of monitoring and diagnosing. So in a way, we are suddenly being exposed to such a large amount of data and insights that we actually don't even know what to do with yet.
Yeah. I was thinking about the two examples that you gave here, which leads to our next question about how you foresee AI and these sorts of interventions that you've talked about, changing how we offer treatment and how personalized treatment plans are going to become the new way of providing care. That patient on chemotherapy with the predictive analysis of whether they're going to have a reaction or an adverse outcome from a cardiac point of view, diagnosing or predicting that AFib, beforehand. These are all things that we can already, whether we know what to do with it at this point or not, I think, research comes in phases. First, we have to prove that it's viable and validated. And then we'll continue, and this work goes on. You're citing studies that are, 5, 6 years old, when some of the algorithms and the aspects of machine learning and deep learning weren't even possible for us.
Correct.
So as we learn more, how do you foresee these algorithms changing personalized care treatment plans in cardiology?
I think, I don't think, I'm almost certain. See, just if I simplify the matter, the more you know about a person, the more information. The purpose of us taking history is that, hi, how are you? Well, I need to know your name because I know who to address. But then I'm going to ask about your age, your sex, because then I add data points to the demographics. And then I'm going to ask you about the family history so that I know if there are any genetic predispositions and certain diseases. And then I'm going to ask about symptoms, positive symptoms, negative symptoms, medications, exposures. Each one of those questions, hopefully, or at least in the traditional sense of medicine, gives me a data point to either narrow my diagnosis or my thought process, or it will impact what I would recommend. For example, if somebody is allergic to penicillin, then I will be careful with what antibiotics we're going to give. So my advice to that person will change depending on what they tell me. Does it make sense? And this is at the simplest level. The more question I ask, the more you would think I've been thorough in my assessment, and the more likely, if I take all that information into account, will I be able to give a better recommendation. But each one of those questions is a data point. So is every single squiggle in their ECG and every single deflection in their sort of oxygen tracing, and so is every single pixel on their echocardiogram. This is all data, and this data will, if properly assessed, will allow you to be far more not just personalized but precise. And this is what gets us into the whole concept of being very precise with your assessment and with your recommendations and with the diagnosis, provided you know what to do with the data. And that's what we're trying to work out. So precision medicine is, in a way, personalized medicine. And that's even before I get into this whole area of genomics and multi-omics and all these associated data sets that you can get. That's just I'm only talking about their simplest investigations. So in a way, and I didn't even mention anything about their wearables. I didn't mention people with implantable, for example, devices like pacemakers. These pacemakers are collecting data on the second about every breath, about the impedances, about the electrical impulses, about the resistances in their body. We are not using them. Like, we are not even using that data because we are trying to. We are working through it. But the availability, the tsunami of that data is really overpacing our capacity to actually make sense of it. And then you have this interface between innovation and industry and the traditional wheels of medical practice. So in short, absolutely, this is this is a definition of personalized medicine. People's wearables, people's crowdsourced data is, again, something we didn't talk about. It's almost like we're getting to the holy grail of data. It's just we need to find the right ways of leveraging that.
Yeah, that's amazing.
Zaidon, I was quite intrigued when you spoke about using cluster analysis, for kind of creating those patterns and classifying patients with heart failure with preserved ejection fraction. I think that's a fantastic example where actually artificial intelligence can recognize and pick up those nuances of patterns which even a human cannot identify. And
Absolutely.
as we go ahead, I think more and more of such examples are going to come up, and that's going to take us steps ahead into what you were just talking about, precision medicine and personalized medicine. So yes, at one end, there's going to be these wearables that's going to constantly feed you with the data. And then you will have a time series data coming in from their smart ECGs. And I presume you're also working on some similar projects in your university, with smart wearables and smart ECGs. Maybe you can shed some light upon the kind of work that you're doing with them, and we would love to hear on that. And as it goes on, there's also one more important thing that we see. With precision care coming in, you have a very precise treatment being given to the patient. So reducing the rate of complications, improving the quality of life going ahead, and also reducing the extra healthcare cost, especially if it's on the insurance or on the individual's own cost coming. Like in India, we have patients paying out of their own pocket for most of their health. So it's going to reduce that cost burden coming in. So how do you see that whole, paradigm change happening, now that we are all starting to explore these personalized medicine and precision medicine, and then going ahead, we are looking at a place where these are actually going to impact the real-time healthcare in real, maybe in the next 5 years and 7 years. How do you see this whole shift coming?
To be honest, I am quite grappling with that concept. And at sometimes I even carry a very pessimistic view. Sometimes you see yourself quite excited about what can be done, about all the knowledge that you can unearth, and about all the insights you can get, and how much, better you can be at advising your patients and about detecting problems early. But the reality is, and just to ground myself, from a cardiac perspective, and that's just for grounding, just to remind myself to be humble, most cardiac diseases and complications, and so are, endocrine metabolic, are lifestyle diseases. And they are mostly lifestyle diseases. And for the first time in our life, at least in this generation, the life expectancy of people being born now is actually worse than the people who were born, years ago. So we are going backwards after years of improvement, despite everything. And there are many reasons for that. The reasons is, the sort of our economic lives, the stress, the working hours. There are so many reasons, the food, you name it. I can summarize cardiac, and one of the fathers of cardiology that I have huge respect to is Professor Dudley White. He is the White and Wolf Parkinson White. He's also the cardiologist who brought the ECG machine from Eindhoven into the US. He popularized the ECGs. And he's one of the founding fathers of the Framingham Heart Study. And he summarized cardiology and heart disease, as eat less, sleep more, and walk more. So having that grounding, going into what I think wearables and AI and all of that can do is probably it can engage people with elements of their health. It may be able to visualize to people things that, because everybody thinks that it's not going to happen to them. And for example, when I use CT scans, when I use CT coronary angiograms, the main purpose is not just to make a diagnosis, but to show the person, this is the plaque that I'm talking about. We can either drop your cholesterol through these methods, or, there's only one way this plaque is going to go. So I think it allows us to be more, take it from the hypothetical and say, if you are not healthy, you're going to have a heart attack, into something more tangible. And especially people like tech, they like wearing watches. They like, maybe we can engage more. I see that as one way. From a research perspective, obviously, it's a different game. It's a different ball game. We will be able to advise, but we've advised people in the past, just walk more, eat less, sleep more, So maybe it allows us to engage a little bit more. On the dark side, I am concerned that this data, this information, is probably might make its way to insurance companies to say who is worth paying how much before it actually makes it to people to engage. And finally, especially now that we are moving towards preventive, what this allows us is to move not only to prevention, not just secondary prevention, but be more effective at primary prevention, and even better, take it to primordial prevention. And primordial prevention essentially means you prevent even, like, you don't prevent a heart attack, you prevent the development of high blood pressure, or you prevent the development of even insulin resistance, The problem I foresee, and that's why we need, a lot of conversations about that between academics and people. Suddenly, when you go to a healthy population, you don't want to convert someone who would otherwise have been considered healthy into a patient. You don't want to label someone who does not have any symptoms yet and might have some elements of a lifestyle, but in reality, into a patient with a risk label on them. So we should be also very careful about what we tell people and how we get the message across and what to look for. So it can get very complicated in that sense. And for people with, with familial problems, it'll be great to capture them, but also without good, adequate sort of guardrails, they might be denied the right in healthcare or insurance. I mean, who knows?
Yeah, I mean, I think you bring up so many larger points that could probably create, 15 more podcasts around democratizing healthcare and access and cost. I share that the optimism balanced with the pessimism on most days, because I do think that we have to be very careful about how these tools are implemented into our practice. No doubt that they will change how we practice. I think the way we take a history will change in the upcoming years, because it will be informed by a lot of these algorithms that have the information for us, right? And I think it'll change how we advise in the preventive space, to your point around the primordial prevention of various diseases. So yeah, go ahead.
Right. No, sorry. Which again, and I think probably the best thing we can do is to share that knowledge with the population. I mean, if kids are raised, with that knowledge, with that understanding, you kind of, you're able to visualize, to educate, to spread these insights across the population. And I think this is one potential where it can make a huge difference, rather than having an unsuspected population living their current life as we do, and we're sitting there exposing them to all these algorithms and coming out with all these numbers that we don't understand. And
well, I was going to say,
you've been judged. Exactly, you've been judged.
It's too early to know what we're going to do with all of this information. But and to that point, I guess that leads me to our next question, which is how AI can be used in predictive analytics to forecast potential cardiac issues. You've touched upon this with various examples around AFib and heart disease and the prevention of MI events, myocardial events.
Yes.
So are there other areas that you foresee where predictive analytics will continue to make an impact for us?
Let me just probably I might have to get slightly technical here, but
please do.
So AI picks up a pattern. And the problem, for example, with the current generation of deep learning is that we don't always know what that pattern is. But that can raise a problem. But even if it allows you for a pattern, I mean, this is not something that a physician or a clinician can talk about, but this is the sort of thing that a mathematician is going to try to unravel, where are the weights being assigned? But let me give you a little bit about two examples, one an ECG and one on CT scans. The ECG, I'll be talking about my own study. So what we use is something called advanced ECG. And if everybody looks at an ECG, what you are going to see is 12 squiggles, and we call them a 12-lead ECG. Some of these squiggles are acquired by direct measurement of the electrical current between 2 points in the body. So, for example, the electrical current of the heart between the right hand and the left hand, between the left hand, right hand, and the left leg, and between the heart and the front, for example, of the chest, at the front, at the side, etc. And some of them are derived from that. But what that ECG actually is measuring is the movement of the electrical front in the heart across the heart, which is, as you would imagine, a 3D phenomenon. So it happens in all directions. It's not a 12 single lines. So there is a vector component to it. There's a vector that goes into the x-axis, the y-axis, and the z-axis. And that is called vector cardiography. We don't do them in clinical practice, but that's the way the electrical impulse is propagated. And if there are issues in certain cardiac chambers, then the relationship between the loop of one part of the heart and the other heart changes. We can't detect that with our eye, but we can detect it if you do advanced analytics of this, of the ECG. Furthermore, There are concepts that are even I am finding hard to quite visualize, even though I'm studying them, which is like, eigenvalues and the complexity analysis of the impulses. But if you do that for the ECG, plus the usual metrics and the usual measurements, using advanced analysis, you end up with 5 to 600, more than 500 variables for every ECG. These are mathematically derived variables. You know what they are, and you calculated them from an ECG that you look at. Now, you can look at your ECG as the squiggles, or you can make it to these variables. But how do we understand these variables? We don't quite understand them. So we needed to study them on people and see what they represent. And there was decades of work done at various people in various centers, on healthy people, on less than healthy people, on people with coronary artery disease, and normal nomograms and normal values have been established. And we are able to make predictions, for example, using that on who has what, who has left ventricular systolic dysfunction with a certain confidence interval. Obviously, these things are evolving and continuous.
Mm-hmm.
So in this example, I just showed you that this ECG that is just a 12 lines, that AI, when you break it down into voltage versus time, can see more than just the squiggles. And this is one example of how to slice it and to look at it, which is, what we call advanced ECG. This kind of science would not be possible without these computing powers. Essentially, you're just looking far more in depth to make these. And that way, you can make predictions. You can also say, I am making this prediction because of these variables. Now, could this be a true prediction, or is it a false negative prediction? This is where ongoing research, and you try to set your positivity point and negativity point, just like a blood test, just like anything. This is how we can predict we can predict a lot of things from an ECG that way. And that's one example. And that's using only ECG. I didn't even mention age. I didn't even mention, any other variables into it. One very neat study that I found fascinating came from Oxford. And essentially, they had thousands of CT scans, coronary artery CT scans, like pictures of the coronary arteries, done at people who were enrolled in trials. So they have the follow-up data for them for over the years. And they were very high quality studies. They came up with this new metric that doesn't look at the blockage. It looks at the fat around the artery, and they can estimate how inflamed the fat is. Because if the fat is inflamed, which is the precursor to actually the plaque happening, and it's a precursor to cholesterol developing. If the fat is inflamed, surprise, surprise, the water content of the fat is different from the water content of a healthy fat. Now, this is an example of an amazing, an amazing physiological grounding that you can see with the machine. To our eye, if you look at the fat around the artery, all you see is just shades of gray. You can't see more than that. But when you actually break it down to more, and this is example where, our eyes are aided and you can make predictions. So in fact, the publication, it was back in 2019, but I consider it a landmark publication. They can even predict who is going to have a heart attack, even though they had a normal artery, completely normal looking artery, who would have a heart attack in 5 years, based purely on the levels of inflammation in the CT. And these kind of things are almost scary, it's almost like having a crystal ball.
It is magic.
It's just but that's an example of how you use, if you have the right idea, you have the right data, you have the right points, and the ability, you can actually predict a lot of things. Not just a prediction, not just like palm reading, but you actually have physiological grounding, and you have data points that are solid and defendable, and you can look at them. So this is what I find it quite fascinating.
That's an amazing study. I'm going to have to go find that one.
Yes, it's an algorithm now that's actually approved by Caristo Diagnostics, I think.
Mm-hmm. That's
So
fantastic.
it is fantastic, absolutely. So that's
Zaidon, what you just did was like you took a very technical aspect of the cardiology and you kind of broke it down into simple terms in a very simplified way for all of us to understand. And although this is like all our viewers are doctors and people from the medical professional, but it was fascinating to hear that coming from you. And that just reminded me, this is just the way you ask a chat GPT, like explain a triple vessel disease the way you would explain to a 10-year-old. So Zaidon probably just did that. So let's just kind of, lighten the part a little bit here and video off a little because I think I'm having a low bandwidth. So let's just try to understand here how you see artificial intelligence impacting cardiovascular research, especially, when you're dealing with complex heart diseases like the congenital.
yeah.
All of that.
Yes. No, I got it. Again, where do I start? I think it's not just AI. Before we talk about AI is the application. Underpins AI is data science plus engineering plus all these sort of allied or affiliated specialties to make it possible. What I find most fascinating, or is going to probably emerge, is how we actually define what evidence is. So, for example, clinical researchers, and this is my pet hate, a clinical researcher would come and tell me, we have no evidence that this treatment works or doesn't work. We have no evidence that this person has coronary artery disease. And you can, be quite Socratic about it and say, what do you mean there is no evidence? How do you know there is no evidence? Now, first, as we were speaking, probably a couple of thousand papers would have come out somewhere. Did you read them before you told me what you think the evidence is now? Did you? So the point is, you can see medical knowledge was doubling every, few years, and then it was doubling every few months. And then it was doubling, I think most count, and the latest count, it's doubling every, 50 or 60 days. That knowledge is not just knowledge, but that knowledge is also data. That knowledge is information. Before I speak specifically about cardiology, data science and the ability to use tools of data science like AI in its various manifestations will allow us not only to consume evidence, but actually to redefine what evidence is. And I think we are going to, Amit, you would know that we, I have to give credit to, my mentor, Anthony Chang, who came up with the term of intelligence-based medicine. And intelligence-based or data-driven medicine is probably there to go. I think this whole concept of evidence-based medicine is falling apart. It did not keep up with COVID. It lay completely helpless in COVID. And people are realizing from other industries, computers, data science, they're looking at us as like, we can't believe this is your only way of estimating evidence. Now, there's a very good reason why we are very conservative about our evidence because, it affects lives. It affects life, it affects it affects essentially human well-being. But there are more ways to establish evidence. And I think this is one of the ways in which is going to turn research on its head. Where do you find your data? How to use your data? How to draw evidence? And using methodologies that are very new to us. I mean, doing a Fisher's test and trying to do a linear regression and get a p-value, that's not going to cut it. So we need to learn a lot. There's a lot for us to catch up to. We should also understand that research is not just an Excel sheet with rows and columns. It's data is far more, data comes in all forms and shapes these days. And this merger of multidisciplinary research really is what I see is going to be absolutely turned on its head. How well we perform, I don't know. We're still siloed. But you simply can't, you can't just see one person after another, fill up your Excel sheet, and then, try to do a couple of that, like that turns it. On the other side, I am immensely thankful for ChatGPT. I mean, I've been trying to learn R, it was really doing my head in because it's so silly, the syntax, but I have to use it for medical statistics. And now I just go to ChatGPT. Hey, mate, can you please, I want to do this. Give me the code. Often it gives me the wrong code, but the good
I
thing,
was
it
about to
troubleshoots the
say,
code.
yeah.
No,
I
it
was about to
troubleshoots
say.
it. I eventually get where I need to go. There's no more for me spending hours on Stack Overflow. Why on earth does this button not work? Why does this code not work? So it's fascinating. And that's even before Copilot and Pilot X and all these things, which makes life easier. So it really, put it that way, AI, not just AI per se as an application, but the merger of data science and medicine is just going to redefine research. I can't see research happening in the same way on Excel sheets, just.
Yeah.
So,
And also to just add to that, when you talk about complex cardiac disease, which my question was on to you for that,
Yes.
also about the rare diseases, we also have something called synthetic data. And that's going to like change everything. If you have a rare disease, you don't have enough data, you can kind of emulate and create a synthetic data. And then there's also something called, general adversarial networks. You kind of generate a synthetic image to increase the specificity. So just give us a view on that.
You took the
Yes,
words right out of my mouth, Amit. That's exactly where I was going to go.
yes. Well, I have some of the people in the group who are specifically interested in rare diseases and congenital diseases. You may be aware that the team at Children's Hospital of Orange County, where Anthony Chang is, they have their Moonshot project where they try to connect, all pediatric units at once to try to pull all their data, and collaborating. And this is where this is the point I'm trying to say. Before we go into AI, understanding that you need to pull your data, you need to train it, to store it, to share it in a certain way, in a federated way or non-federated, depends. Having that layer of data availability is critical. And that's not something we would realize. In the past, we would, take pictures, put them in a CD and store them for privacy purposes. That is not going to cut it in this day and age. So first and foremost, collaboration between different institutes is happening now to share their data, to share their expertise on rare diseases, on their images, on their research outputs, but also how to amplify weak signals is a whole science in itself. And whether it's using GANs, generative adversarial networks, or whether it's using, minority oversampling techniques, there are lots of technical abilities to actually amplify weak signals in small data. But the basis is actually to think about it in a different way, to think that this is a treasure, this is a responsibility. Put it that way. The way I always have fights with our IT department, and I was like, like for example, we would one of the projects was to do digital ECGs, but they are not storing the waveforms at one point. They thought, oh, you have the picture, and I was like, you don't realize that the waveform, the information it contains, it's exactly like a patient coming to you, you spending an hour talking to the patient, get a history and a physical examination and some tests, write them down on a paper, then take the paper, tear it apart and throw it in the garbage, just writing the diagnosis. This is exactly what you're doing. So the nuances in the data, the importance of the raw data, the attempts to store that, process it, that whole mindset did not really exist in many places in the past. And this is where we need to be very cognizant. And yes, there was an important study, fascinating, published again a few years ago from, I think, Rady's Children's Hospital, where they were able to read the whole human genome of a child who was not thriving in intensive care. And they were able to, and that was before ChatGPT, they were able to just get all the text in the file, every single finding, rather than somebody trolling through it. They just took all the clinical notes for the sick child. They combined it with their genome, that was read within 24 hours. The algorithm managed to narrow down the list of possible pathologies into 3 out of thousands of possible genetic mutations that are extremely rare. And I think it was a deficiency of a certain amino acid that once replaced, the child started thriving immediately. This is unheard of in the past. So essentially, you just read the whole genome within a few hours and combined, rather than you picking what disease, you just did natural language processing before the days of GPT. That was unveiled to the world on all the clinical notes that everybody's put in the child's notes, and it narrowed it down. And this is an example of the possible power of where this can lead, as an example for rare diseases.
That's amazing. I mean, yeah, that is amazing. And I think that leads us to our last couple of questions here. And then we'll close with some thoughts. But where do you see or foresee AI having the most significant impact in cardiology? I think you just gave us a very good example of that. But I also think that that's rare disease, right? Like that is 1 in a million, 1 in 10,000.
Yes.
But I think the impact is going to be on a much larger scale when it comes to all things cardiac, right? Heart disease just being one aspect of cardiology.
Yes. We don't need to go far. The biggest impact on reducing cardiovascular mortality has been in prevention. I mean, we don't like to acknowledge that, but it's been preventive. We did not know that there were risk factors before the Framingham Heart Study. In fact, the term risk factor was coined after the Framingham Heart Study. And even if it seemed to be quite basic to our understanding now, at the time, these risk factors, these factors that lead to disease, I think AI can do not only the same thing, but I think the biggest impact is the capacity to engage with the wider public and increase awareness and probably give people access to look after looking at your steps, looking at your heart rate are the simplest examples that might not be quite impactful. But as algorithms become more sophisticated and people have more ownership of their data and hopefully that will translate into more impact before even we talk about interventions, because the interventions is an endless pit. It's very costly. It's not the most sustainable way.
It is emerging of, fitness, wellness, and health. I think that's the distinctions if we want to put them in categories. We focus as providers on health, but the fitness and the wellness part of the things, those are the larger things that the patients themselves have control over.
Health literacy. And I think ChatGPT and language models might be able to even help with that if deployed properly.
Yeah.
So I think that'll be the biggest impact.
Yeah. So from essentially, from sick care, we are calling from actual healthcare with preventive and primordial kind of, prevention coming in. So I think we come to the last question. I think this is a very important question, and I'm sure a lot of our cardiology friends would be glued today with the podcast, and they've got a lot of insights, and a lot of aspiring cardiologists and students are going to gear themselves up with, artificial intelligence. So what are your recommendations from them? There's a lot of paradigm change happening, and, we all have to go with the pace. So what do you recommend them, in terms of developing some special skills or take up some special training so that they can adapt to this ever-changing landscape of using AI in cardiology?
Absolutely. Look, it is hard. The reason it is hard, because if you asked me 3 or 4 years ago, I would have said, start with learning Python, and then from Python go backwards. You can apply and get your hands dirty. And I would always say, to me, Python is definitely far more relevant than the Krebs cycle. I mean, who cares about the Krebs cycle?
Yeah. Oh my God! Don't say that out loud to anyone.
And who cares about the electron transport chain? I mean, I just remembering all the hours I spent in this, useless toil.
Didn't we all?
Maybe it facilitated certain pathways in my head that are now I'm using. I don't know, but I certainly, I get a rash every time I hear the Krebs cycle. But now the skills you need have really changed. You don't really need to know Python. I mean, it'll be useful to know a little bit of pieces to put examples together. In fact, I think you need to put yourself with like-minded people would be my first advice, because the range of skills you need to develop will depend on what you want to do. Do you want to be a researcher? Do you want to be an entrepreneur? Do you want to be a data scientist? You need to find your niche. That you cannot be a master of all trades. I thought I could. I wanted to a few years ago. Now I'm just giving up. I was like, if you're able to do one thing, and well, even if that's just, even if you're only good at prompting an LLM, then you're already ahead of so many people. Having said that, I think it is critically important for us as learned individuals and as dispensers of advice and dispensers of hopefully sound knowledge is to have basis in data science, to know at least what the algorithms are, what the pitfalls are. And when somebody comes to try to sell you an algorithm to change the world, you know actually how to pick it apart, because there's nothing wrong. There's nothing worse than implementing and investing in the wrong technology and the wrong place. So I would say find like-minded groups and people, keep talking to them. These things keep changing. The American Board of AI in Medicine and the groups that you have, local, international, everybody is friendly. Try to be more versed, digitally dexterous, not just AI, but it's a big space. And if you try to encompass all of it, you won't. Try to find your niche. Try to find what you want to do. Entrepreneurship, research, education. It's you just explore, hear about things, and then find what is it that you like to do. That would be probably my advice. But don't ever try to shy away from it. You're going to be in trouble. If you're a medical student and you don't get into this space and try to understand it, I would consider it negligence. Maybe it's a strong word. I would consider it negligence, gross negligence. It's like you're omitting vital information that's going to impact you, your family, and your patients.
Absolutely. I couldn't agree with you more. In fact, I have a couple of things when you were talking about providers with our spreadsheets that we use, that we call research, or calling it, I was actually talking to a friend of mine recently who is in the process of really taking a really large spreadsheet, which is supposed to be a data set at this point. And he's like, it's a mess. He's like, providers don't know how to collect data and do research. He is actually using Python to help clean up the data so that he can make it usable. And so to your point, and that carries into my next point, which is what you were saying, is that you should learn about this space. Know that we are going to have new partners on our clinical care teams, such as data scientists and data analysts, who are going to be crucial to how we practice in the future. And we can't do it without them. We cannot provide care in the future without them. And to the medical students and the ones who are thinking of pursuing healthcare, math is important. You heard it here, right? If there is one thing you need to know now, the math is going to be really the thing that's going to drive a lot of the things that we do now.
To medical students, my advice, you need to be bilingual without an accent. And I'm quoting this from Anthony. You need to be bilingual. Absolutely. In fact, I might just put down all of life is to try to find the signal and the noise. You want to know, separate the noise and find the signal. You can be very philosophical about it, but essentially this is the essence. And data science is really the science of trying to do just that. So you need to be bilingual. To medical students, Krebs cycle, maybe not so much.
Maybe not so much.
Yes. Well, I think that's a takeaway, Krebs cycle versus Python. I mean, that's a fantastic comparison there. But I mean, three important things, got to be curious, you got to be adaptive, and you've got to keep learning. And these three things are very, very important in the life of any medical professional. And with all these dynamic changes happening, I think it's really important. So I think it brings us to the end of a fantastic conversation. But before we end, we have a lot of viewers and they must be having a couple of questions. So we'll just kind of stay back and take maybe one or two questions if Harshita can bring them to us.
Yes, we have received questions from our audience, and many of which have already been thoroughly addressed. So, however, we'll take one question. So how do you believe AI-driven personalized approaches will impact the efficacy and outcomes of cardiac care? And what steps are being taken to ensure equitable access to such cutting-edge technologies?
Well, you can take over the second part. The first part we have already sort of discussed.
Yeah, the first part, I think, again, the more you know, the better you can personalize your the points, and it's all about having, you know, the right data at the right point in time to actually generate the right insight.
Yeah.
Equitable access. You know, I have to quote from Leo Selly, who's one of the you know, one of the leaders in this field from MIT and Harvard. And essentially, his view is that if something is not built with equity at its outset, it should not be built. And I think I have to agree with that, because the last thing you want to do is exacerbate the divide between those who have and don't, and between those. And especially if you do this with AI, you do this at a scale. The issue here is this is not a responsibility of a single person. I mean, I can advocate for that, but this is a societal responsibility. It's a government responsibility, but government, again, you know, if you argue that there are democratic governments and democracy, you would say it goes back to society. So this is where education and knowledge of the common man and woman about AI is paramount, because people need to know, you know, the first rule in medicine is to do no harm. So it's good to do nothing before you start doing something. And that can be applied to AI as well. It can't be, you know, physicians are not necessarily in the driver's seat in this. There is, you know, the biggest companies on earth are trying to drive this in one way or another. Physicians and healthcare workers cannot be you know, the keepers of the gate forever. This is a societal responsibility before it's only medical. So equity is probably the issue number one, because it opens up the gate for so many issues. Are the algorithms, you know, equitable? Are they trained on the right population? Have they been sourced? Have the algorithms been sourced you know, ethically, or have they been stolen from disadvantaged population, for example? And for example, if you want to do this whole thing about representation, and you need to have the, you know, a representative population, did they consent? There are so many issues. And the WHO actually published a very nice paper, and I encouraged everybody to read it. If you just look up WHO ethics of AI and machine learning, ethics of AI, and the advice goes at the societal and governmental level.
Yeah.
Again, when we talk about government, we should also understand that there are competing interests sometimes between surveillance and social control, and between actually providing what's best for the society and community. So these are existential questions. I don't want to get into that, but the point is the responsibility is on everybody. So it's an excellent question. There's no definite answer. It's actually a very difficult thing to answer.
And as we go ahead, we're actually exploring this, you know, globally as well as regionally, about this ethics and the equities. So that brings us to the end of this fantastic discussion. And I really thank Zaidon for all his inputs. I mean, it's been a fascinating conversation, getting all the insights and all the nuances happening in the field of cardiology. And that's fascinating. So folks, this month we've come up with 2 specialty podcasts. I mean, we had one on pulmonology with Dr. Piyush Mathur, and now we had one in cardiology. And now Dipu is going to tell us about next month's episode. So we'll take a highlight from her before we close.
Yeah, so we have coming up in March, someone who is actually doing a lot of work in the med tech space. So we're going to talk about the technologies and various other aspects of, I'm sorry, I'm drawing a blank on the name, Benny Aspera, excuse me. And our second guest in March is going to be Emmanuel Mitrichin, who is going to be speaking on blockchain and AI. So very interesting and diverse topics. We're going to shift our gaze from specialty practice, pulmonary cardiology, and expand it into the med tech and blockchain, things that we don't know how is going to be impacted by AI. So looking forward to hosting those in March for you.
Yes. And then again, we'll come back with some specialities maybe in subsequent buckets. That's right. Thank you very much for joining in. Over to Harshita.
Great, thank you. As we draw this enriching conversation to close, I extend my heartfelt gratitude to our distinguished guests, Dr. Zaidon, Dr. Amit, and Dr. Dipu, for their invaluable contribution and insights. To our audience, I express sincere appreciation for your engagement and curiosity. Your presence enriches our dialogue and inspires us to continue pushing the boundaries of healthcare innovation. Thank you for joining us today, and until we meet again, stay informed, stay inspired, and above all, stay healthy. Goodbye.